is the Onco'Zine Brief with Peter Hofland.
In this edition of the Onco'Zine Brief, I'm talking with Dr. Leonard Farber, a board-certified radiation oncologist and healthcare executive. Dr. Farber is recognized for his ability to identify groundbreaking technologies and position them for success in clinical practice. He recently joined EHMET Health, an emerging medical device company with a state-of-the-art device for providing radiation as a treatment for breast cancer. Dr. Farber joined the company as the Chief Medical Officer and the Executive Vice President of Clinical Research. Dr. Farber also works with a large number of pioneering startups focusing on health and medicine, including companies such as PreludeDx. In today's program, we talk about ductal carcinoma in situ, or DCIS, and DCISionRT, the only risk assessment test for patients with this disease that predicts radiation therapy benefit. I'm Peter Hofland, and this is the Onco'Zine Brief. The Onco'Zine Brief is developed in collaboration with our online journal, Onco'Zine, at Onco'Zine.com, where you find additional information and the latest news about cancer, cancer diagnosis and treatment, and cancer prevention. For information on how to support the program, visit our website at Onco'Zine.com. And if you're living in the United States and want to receive our newsletter, text the word cancer, that is CANCER, to 66866. And we will make sure that you'll receive our newsletter, which includes an overview of the latest news in oncology and hematology. On the phone with me is Dr. Leonard Farber. Dr. Farber is the Chief Medical Officer and Executive Vice President for Clinical Research of EHMET Health. Dr. Farber, welcome to the Onco'Zine Brief.
Great. Thank you for having me.
You are a board-certified radiation oncologist. You've helped to treat patients who were diagnosed with ductal carcinoma in situ. Now, before we're going to talk about diagnostics and treatment options, tell me a little bit more about this form of cancer. What is ductal carcinoma in situ?
I think that's a great place to start because there are a lot of preconceptions of what it is and what it isn't. So ductal carcinoma in situ, and the acronym is DCIS, it's a type of cancer of the cells that line the breast ducts. And the ducts are these very thin tubes that carry the milk within the breast. It's considered to be a stage 0 breast cancer, but it is still a type of cancer. Yeah, sometimes it's referred to as pre-invasive or precancerous, but it is the type of cancer that does not spread. And that's where the term in situ comes from. So it's non-invasive cancer cells that do not spread.
Now, if you look at a typical patient, what are the risk factors associated with DCIS?
The main risk factors for DCIS or ductal carcinoma in situ are very similar to risk factors for invasive breast cancer. We look at family history of breast cancer, a patient who may have had a personal history of other non-cancerous breast conditions, for example, something called atypical hyperplasia or atypical ductal hyperplasia. We look at genetic mutations that are associated with breast cancer. Everyone's familiar with the BRCA or BRCA genes, so genes 1 and 2. A late pregnancy, becoming pregnant after the age of 30, taking estrogen or progestin hormone replacement therapy for a significant number of years after menopause, and probably even a high body mass index, so obesity, excess body fat in relation to the patient's height is also a risk factor. So you have everything from genetics to environmental, and you have things that the patients can affect themselves.
It sounds to me that there are many different potential risk factors. What if someone recognizes some signs or symptoms before being diagnosed, something that may concern the patient or their partner? Tell me a little bit about this, because in the initial development of ductal carcinoma in situ, there is not an immediate or obvious diagnosis. Is that correct?
Correct. For the most part, unless it has become very advanced, it's typically something we'll find on a diagnostic study, such as a mammogram, an ultrasound, an MRI. But after a period of time, especially if left undiagnosed, you can have clinical findings. You could find a change in the skin of the breast tissue. You can see redness. It can even become palpable. We see that actually a lot more in Europe than in the United States, and that just may be differences in terms of follow-up, in terms of guidelines for screening and that sort of thing.
Now, about these guidelines, the ones that we have here in the United States, there are certain guidelines dealing with screening. Tell me a little bit more about that.
Well, it's constantly evolving. We typically, in the United States, follow the American Cancer Society guidelines. So the indications for patients between the ages of 40 and 44, those are really discretionary. That would be for women who've had a personal history of breast cancer or high risk factors for breast cancer, one of them being genetic component or having a strong family history. We start to kind of get into a grayer zone for women between 45 and 54. If they've had one or more breast cancer risks, those are usually recommended for once per year. And now for women 55 and older who are otherwise in good health, we go into every other year. But we've seen those change, the guidelines, over the years, but this is currently where we are for the American Cancer Society. And it's confusing for patients, and often scary if you're younger and you're worried about your risk factors. So if you have a strong family history, strong personal history, then typically you're at an annual screening.
Some patients may have previous incidents of breast cancer. This form of cancer, ductal carcinoma in situ, is an early stage of breast cancer, sometimes referred to as stage 0. But can this form of breast cancer occur in parallel with other forms of cancer, maybe a later stage or more invasive form of breast cancer? Or is this diagnosis of DCIS always the first time that someone is being diagnosed with breast cancer?
Well, you can get an invasive breast cancer and have ductal carcinoma at the same time. Oftentimes during a biopsy or even the lumpectomy, which is the surgical part of the treatment, or even a mastectomy, you can see both DCIS and invasive breast cancers combined. So DCIS is often treated because of its higher risk of becoming an invasive breast cancer over time if left untreated. I think of it as being on a spectrum from stage 0 to 1, 2, 3, 4, 2. And in that spectrum, we're going from the lowest or highest curable type of cancer to less and less curable as we become more advanced staging. But the goal is to treat it when it's at its earliest stage.
Right. That earlier stage is just to make sure that people are going to be screened, to make sure that cancer can be detected early, right?
Exactly.
Now, let's talk a little bit about treatment options, because there may be a little bit of confusion about the treatment options in general. For the majority of women that may be diagnosed with ductal carcinoma in situ, what are the treatment options that are available?
It's really a great question, and it sounds simple. We'll start with the simplest answer, but it does get complex. So the standard of care would be to do either a breast conservation surgery plus radiation, and this is where we'll get into a bit more detail, or a mastectomy. We're also looking at subcategories of patients who can just get away with lumpectomy alone, or sometimes even for very elderly patients who have other high-risk factors, is actually to leave it untreated, which is very, very uncommon. So that's not something we usually will advocate. The two categories, so coming back to the original answer, is to do a breast conservative surgery approach, which is typically a lumpectomy or partial mastectomy. And that's followed by radiation therapy. And there are many forms of radiation therapy after surgery. You can do external beam to the entire breast. You can do external beam to a partial breast. You can do internal radiation, so using radioactive implants. Typically, you will add on a hormonal therapy, an estrogen blocker, such as tamoxifen or an aromatase inhibitor, and that can go hand in hand with the radiation. And then on the other side of the spectrum, the more invasive type of procedure is to do a mastectomy. And typically, a mastectomy will not require radiation afterwards, but patients may still require hormonal therapy.
So when you look at the last option, mastectomy, that means that there may be a need for reconstructive surgery. Is that part of the treatment options that are out there?
Yeah, well, reconstructive surgery is really discretionary because it becomes more of a cosmetic and obviously psychological issue. It's not part of a cancer curative approach. So the reconstruction, the idea is to cosmetically have, if you're doing a single mastectomy, is to try to match and have a woman have a sense of completion or a wholeness again. And that's hence the psychological impact. But it's not required in order to achieve a goal of cure for DCIS.
Let's take a break. If you're just joining us, in this episode of the Onco'Zine Brief, I'm talking with Dr. Leonard Farber, a board-certified radiation oncologist and healthcare executive. Dr. Farber is recognized for his ability to identify groundbreaking technologies, and he can also position them for success in clinical practice. I'm Peter Hofland, and this is the Onco'Zine Brief.
The Centers for Disease Control and Prevention is encouraging cancer patients and survivors to be extra cautious during the COVID-19 pandemic. Cancer treatment, especially chemotherapy, weakens the immune system, making you at higher risk of severe illness. Dr. Lisa Richardson is director of the CDC's Division of Cancer Prevention and Control.
Take these steps to stay healthy. Wash your hands often with soap and water. Clean and disinfect frequently touched surfaces daily. Stay home. If you must leave, keep at least 6 feet between you and others. Avoid touching your face, eyes, nose, and mouth with unwashed hands. If your temperature is 100.4 or higher, call your doctor. Use CDC's coronavirus self-checker to help you make decisions about seeking medical care.
Make sure your caregivers and household members are aware of your higher risk and take precautions. Visit cdc.gov/coronavirus and preventcancerinfections.org for more health tips.
This is the Onco'Zine Brief with Peter Hofland.
And welcome back. This is the Onco'Zine Brief. If you're just joining us today, in today's episode of the Onco'Zine Brief, I'm talking with Dr. Leonard Farber, a board-certified radiation oncologist and healthcare executive. Let me go back to the available treatment options. Patients may be concerned that after treatment, a cancer may, over time, recur. Is that also the case with DCIS? And if that's the case, what are the treatment options at that time?
Yes, very much so. If you go back historically before advances in radiation, the DCIS was typically treated by a mastectomy. And as we advanced in our screening, as we advanced in our treatment, we started to explore lumpectomies, again, also called partial mastectomies, followed by radiation. So with or without radiation therapy. Now, historical studies going back several decades ago have shown that for the majority of women, and we're going to start in a very general sense of data, that for the majority of women, radiation will add a benefit in terms of preventing the risk of breast cancer from recurring, meaning it will prevent the risk of DCIS coming back and prevent the risk of anything coming back within that same breast. So DCIS and or invasive breast cancers. I use the term historical because the recent data have changed. The historical data has shown that if you add radiation after you do a breast conservation surgery, you have a decrease in recurrence rate about 50%. And that's historical. And today we're going to get a little bit into the more details of DCISionRT to show how those numbers have shifted in a very positive way with this genomics assay.
That's also one of the things that came out during the last few meetings of the San Antonio Breast Cancer Symposium. Now, tell me a little bit about this, because there are a lot of different components, right? There is the diagnostic part, and the diagnostic part can be very complex because there are different steps in there. And one element is the genetic component. Tell me a little bit about that component and how that may benefit patients. For example, a patient trying to figure out if the cancer is an early cancer or is there a familial link to that. Tell me a little bit about that.
Sure. And if you don't mind, we'll talk a little bit about how we look at risk within the molecular tissue, if you will. So I'm gonna go back an additional step. And the way that we've looked at the risk of recurrences before genomics was to look specifically what we call the clinical pathologic factors. It was looking at, under the microscope, looking at the size of the lesion, the grade of the lesion. Okay, so grade 1, 2, or 3, or low, intermediate, and high grade. Looking at the palpability of the tumor and looking at patient's age. Those were risk factors, even margin status. But today, using genomics, we're looking at other markers. And for the last decade, and even more so, we've had to find out what markers are going to help us determine these risk factors. What I call the next generation DCIS test or assay, the DCISionRT assay, looks at hormone receptors such as progesterone receptor, something called FOXA1. It looks at HER2. It looks at the proliferation receptors. How aggressive are these cells? It looks at stress response receptors and cell cycle checkpoint inhibitors. Now, those are very fancy terms or names for assessing critical pathways that affect these recurrence rates. And you take all of those and you look at historical data, go back and look at these critical pathways and determine how much they affect the recurrence rate. And you combine them with these clinical pathologic features, and now you develop an algorithm. And this algorithm determines the risk factors for a recurrence rate. And that's very different than what we have done for the last several decades, which was just to look at the grade and size and age under a microscope and these other, clinical features. So we've advanced. This is really precision medicine. We're going clinical path to molecular biology, and that's a huge advancement.
You just mentioned precision medicine. We've talked about precision medicine in the Onco'Zine Brief before, and it seems to me that physicians and healthcare professionals and scientists and researchers all have different understanding about what precision medicine actually is. One of my coworkers used to kind of joke about this, saying that medicine should always be personalized and always be precise. Now, those terms may mean something else for healthcare professionals than they mean for a patient or a physician or a scientist or a researcher. Tell me a little bit about where we are with the right definition of precision medicine at this moment.
That's really a great question, and what you said is very true. We should be very precise in what we do. The difference in what precision medicine is that it's using very specific information about a patient's tumor to help them come up with a treatment plan. So usually now we refer to that as looking at their own genes or proteins, but it's taking the patient's specific information using their genetic understanding, their genetic makeup to really understand where their treatment planning can be for them specifically. So when a few minutes ago I was mentioning some of those critical pathways, those are the exact components that we're looking at today to assess a patient's response to treatment. So that's what makes it precision medicine. And it is a precise way, if you will, of figuring out their best treatment options. And that's always going to evolve as we in the medical community learn more and more. So you never stop evolving and you never stop improving the precision of that approach.
Now, often precision medicine and knowing more about the individual patient and their genetic makeup would, to put it in simple terms, allow doctors to diagnose and really target the things they find. We're looking at an era of targeted therapies. How does it apply to your work, and how does it fit in there?
Yeah, and you're exactly right. I mean, this is part of targeted therapy. Typically, when we talk about targeted therapy, we're referring often to drug therapy or chemotherapy that's targeting specific receptors or cells. It is combined in this approach, but with radiation therapy, which is what we're exploring more and more, it's not really targeted to the cells themselves in response to radiation. It's a clinical response to radiation based on the person's genetic makeup. So a little bit different in thinking of a targeted therapy. I think precision therapy is a bit more accurate, molecular approach to precision therapy, but it is personalized. And sometimes people confuse targeted with personalized. So I think of this as more of a personalized precision therapy approach.
Let's take a short break, and then we're back with Dr. Leonard Farber, a board-certified radiation oncologist and healthcare executive.
Hi, I'm Paul Schmidt, one of the many voices of the Onco'Zine Brief. Each week we'll update you about the latest news and information about cancer, cancer diagnoses, cancer treatment, and cancer prevention. We'll tell you what you need to know and why it matters. To learn more, text the word cancer to 66866, and we'll email you our free newsletter or go to Onco'Zine at www.onco'zine.com. The Onco'Zine Brief is produced by Sun Valley Communication in association with Physicians Weekly and the American Association of Medical Education.
Each day, researchers make new discoveries that bring us closer to the moment when all cancer patients can become survivors. Some days they take small steps. Others, huge discoveries lead to giant leaps forward. This progress, both small steps and giant leaps, happens with the help of clinical trials. Clinical trials are a fundamental path to progress and the brightest torch researchers have to light their way towards better treatments. And if you've been diagnosed with cancer, they may be your brightest ray of hope. Clinical trials introduce new hope in addition to the current standard of care, by allowing researchers to provide participants access to cutting-edge and potentially life-saving treatments. So if you're interested in exploring new treatment options while helping to light the path for other patients, clinical trials may be the best choice for you. Speak with your doctor and visit standuptocancer.org/clinical trials to learn more about clinical trials. Together we can stand up for all of us.
This is the Onco'Zine Brief with Peter Hofland.
And welcome back. In today's episode of the Onco'Zine Brief, I'm talking with Dr. Leonard Farber, a board-certified radiation oncologist and healthcare executive. I'm Peter Hofland, and this is the Onco'Zine Brief. Now, let's talk a little bit about clinical trials. You're involved with clinical trials focusing on ductal carcinoma in situ. And as we have seen during the San Antonio Breast Cancer Symposium in December last year, there's a lot going on, not only in DCIS, but in the diagnosis and treatment of breast cancer in general. Now, on a more general level, when you look at breast cancer, what are some of the most remarkable developments you've seen over the last couple of years, and how does that impact physicians and their patients?
Well, we've seen an evolution in terms of trying to determine the best approach. I'm going to focus a little bit more so here on DCIS. In trying to determine which patients would benefit the most from the addition of radiation therapy, because we've tried to find subgroups that won't require radiation therapy, because there have to be some low-risk groups. There has to be patients who don't necessarily benefit from the radiation. And that's an important distinction because we don't want to overtreat. You know, if you don't need a therapy, we don't want to give it. And for years, we've used clinical pathologic features alone. And that helped get to that initial historic benefit of 50%. But the organization that we're talking about, PreludeDx, who has the assay, this DCISionRT assay, what they've done is using 4 different cohorts, so different studies, and over 1,500 patients, where they've taken the slides from studies, so patients who've had radiation or not radiation, and they took their actual slides and they've run the assay on it. And what they did was, having known what type of treatment the patients had after they ran the assay, they showed that if you select out the right group of patients who will benefit from the radiation, and they call these the elevated risk patients, you could have, and this is what they've demonstrated, at least a 70% reduction in recurrence rate. And now we're seeing numbers greater than 75% as we're getting more precise as to which patients benefit. So that's a very important distinction. It's saying that not every patient benefits by 50%. That was the old historical viewpoint. What it's saying is, if you select out the patients who will benefit from this treatment, you're going to reduce that recurrence rate even more so. So you're taking the patients who don't need radiation, you're not giving it to them, and you're shifting patients over to who will need radiation that we thought didn't need it before. At the San Antonio Breast Cancer Society meeting just recently, referred to in 2020, they looked at patients who, based on older trials, were considered to be low risk. And what they found was that, looking at their slides, so they took that risk criteria that was low, and by analyzing their slides with this assay, they found a significant number of patients actually would benefit from radiation therapy. And so one of the things the company has done is said, if knowing that information, are physicians shifting their treatment designs? And we're seeing a shift of approximately 45% in terms of deciding who will need radiation versus who doesn't. To just sort of reword this, we're showing, and this is very important because physicians look at data, and what they do with their data is very important. Are they just, is this a didactic review, or is this something that's going to impact on patient treatment? And we're seeing a significant impact. And that's very important because we're validating the data based on studies, and physicians are listening and applying it now to their treatment algorithms.
That means when you use this assay, you can split out the group of patients that are diagnosed with DCIS and really target or adjust their treatment to their specific needs, whether they may benefit from a lumpectomy or a treatment combination of radiation or other therapies. I mean, you can be very specific to find out a patient's needs. Is that the right thing to describe this?
Yeah, exactly. So it's an accurate assay. It quantifies a risk assessment. And that's very important because it's predicting the radiation therapy benefit for these patients. And it's telling us that not all patients benefit the same. So we're saying that you can have patients who don't benefit at all, and they could just simply have a lumpectomy, versus the patients who are very elevated risk who will benefit significantly from the addition of radiation. And because, going back to our first definition of DCIS, a lot of patients have thought of it as stage 0, meaning I don't need to do anything for it.
Right.
So what we're demonstrating for those patients is, well, you may fall into a low risk category of the within that diagnosis, and a lumpectomy be just enough for what you need for treatment. But it's important to realize, again, that this is on the spectrum. You may be moving more towards an invasive breast cancer, whereby the radiation will significantly decrease the risk of this tumor coming back either as DCIS or, even more importantly, coming back as an invasive breast cancer.
Right.
And now this algorithm, the assay, uses an algorithm that combines the biology and the old clinical pathologic features to individually assess the patient's risk.
Uh-huh.
So a patient can feel better about the decision-making process that when they sit down and have a discussion with the radiation oncologist and the breast surgeon, they're given substantial evidence to support a treatment recommendation. And that's very important because we like to treat based on empiric data that's validated and substantiated.
When you look at this relatively new approach and you look back maybe 10, 15 years, the approach may be very different. I understand that there are clinical trials or studies being conducted today that look at so-called reclassification of earlier diagnostics. Tell me a little bit about that.
Well, the actual development of the assay began as part of a research protocol. It was going back to 2002. So it seems very recent for us because it's now becoming utilized clinically. But it started with an NIH and NCI grant from UCSF and Yale. It wasn't until Prelude became involved in the development and validation of it. That's going back to even 2017. The initial, cohorts started these studies in about that time, 2007 to 2014. It wasn't until about 2014 that we started to get into the blinded validation and randomized trials. So this is a process of development that is well over a decade, almost 2 decades now. And the reason is you need that 10-year data follow-up in order to validate what we're seeing. So the studies are really predicated on having enough patients and having enough data to follow to see if these assays or whatever it is you're looking at actually works.
Right.
Does that answer your question enough?
Yes, it does. It's interesting because this approach really helps to look at the group of patients and make sure that they receive not only the accurate diagnostics, but potential treatment that are really catering to their specific needs.
Correct. And when I was referring to the San Antonio Breast Cancer Symposium, the 2020 presentation, what that did was it looked at some of the other publications, something called RTOG. That was a study group, and specifically it was RTOG 9804. Okay, and that study tried to determine good risk profiles or low risk. Similar, there's another study called ECOG 5194. And they also try to determine which patients were considered to be low risk. But when and those are really only based on those clinical pathologic features. However, when you looked at those and you looked at them from the criteria for DCISionRT assay, it actually was found that a significant number of those patients would benefit from radiation therapy. So you have different studies. But when you apply a more modern approach to that, so you're not negating those clinical pathologic features because the studies are helpful and they provide good information. But what we're looking to do is improve upon that. We're saying, okay, we get that these patients are low risk based on clinical pathologic features, but now we have an assay to take that a step forward. And the design is to add biology to those clinical pathologic features. And when you do so, you now increase the precision of who will benefit. And that's a very important distinction because we're saying now we're not negating what the other studies have shown. We're agreeing with it, but we're saying, hey, can we further categorize the patients and say, well, maybe there are some in that low risk category that will benefit. And that's actually what the studies have shown.
And this is not only benefiting the oncologist, but basically it's benefiting the whole multidisciplinary team involved with the treatment of these patients. Let's take a short break, and then we're back with Dr. Leonard Farber, a board-certified radiation oncologist and healthcare executive.
Sarcoma. Odds are you've never heard that word before. But for the 40 people diagnosed with sarcoma every day, it is a life-changing word. Life-changing and devastating because sarcoma is cancer. Sarcoma is a cancer of bone and soft tissue more prevalent in children than in adults. More than 6,000 people lose their lives to sarcoma each year. Treatment options for sarcoma are limited, and new therapies are desperately needed. More research and increased awareness is necessary to find a cure for a cancer that you probably didn't even know existed until now. Through awareness, advocacy, and research, the Sarcoma Foundation of America is determined to help those affected by this forgotten cancer, to bring hope to the children and adults whose lives are forever changed by a word they had never heard before. Please help us in the fight to find the cure for sarcoma. For more information on sarcoma and the work of the Sarcoma Foundation of America, please go to curesarcoma.org.
This is the Onco'Zine Brief with Peter Hofland.
And welcome back. In today's episode of the Youngsteen Brief, I'm talking with Dr. Leonard Farber, a board-certified radiation oncologist and healthcare executive. I'm Peter Hofland, and this is the Onco'Zine Brief. Now, early this year, in an article you wrote for our online journal Onco'Zine, you wrote about this multidisciplinary team approach. How important is this approach?
Yes, and it's important for the decision-making process on the part of the medical team. For example, with breast cancer, with DCIS, your team typically consists of your breast surgeon, your radiation oncologist, you have a medical oncologist or hematology oncologist, you have a radiologist who's reviewing the images, and you have a pathologist who's reviewing the slides. With a multidisciplinary approach, meaning all of those different disciplines combined together, you look at everything as a whole for the patient. So you're not just having the breast surgeon come up with one concept, the radiation another. You're taking into account all of the features of the patient combined. And with that, you are coming up with a comprehensive approach. So typically this will be done at something called a tumor boards. Some centers have a breast cancer specific tumor boards, and you're reviewing everything at once. When you do so and you come up with a strategic approach, the next step for a patient in the process is to then sit down with their team members. It is typically done on a specialty basis. So they'll sit down with the breast surgeon, they'll have another consultation with a radiation oncologist, another one with medical oncologist. But having had a multidisciplinary approach, the idea is for the patient to get one unified answer. The problem that we had before DCISionRT is that there was this gray zone of who would benefit from radiation. And that's a problem. It's a problem for a patient who's relying on their physician to give them a good guideline. And what this does is it simplifies the process. So the breast surgeon can say to the patient, we'll send you to the radiation oncologist, but they will discuss this new assay that helps with the decision making, and we can review it after the results are in. And it's a way to unify the treatment recommendations. And that's important. This is a treatment recommendation guideline. So it's not the end-all, be-all, hardcore way to treat. You take into account always the patient's decision. You take into account their health, what their needs and wants are, and you use this as just another tool in the arsenal to give a strong treatment recommendation. It's just much easier to sit with a patient and have this printed out form that shows their specific tumor, their specific risk of recurrence with or without radiation at 10 years. And that's very helpful for the patient to see that.
So it really is helpful for the patient. It may take away a little bit of their concern, the fear that they may have. And so it plays a role in what we've discussed earlier when we were talking about reconstructive surgery. And while it may alleviate some of the patient's fear, it may make them feel better about the potential treatment options, including radiation therapy. Is that a fair thing to say?
That's a wonderfully fair thing to say, because there's the fear of treatment with a mastectomy, but there is a very prevalent fear of radiation therapy, so much so that patients can sometimes opt for mastectomy before even discussing with the radiation oncologist. With this assay, let's say a breast surgeon runs the assay and they see a strong benefit to the radiation therapy. It might just be enough to get the patient to come in and discuss radiation with the radiation oncologist, because a lot of these fears are not based on techniques today. They're not based on science today. A lot of it is, fear is fear for whatever the causes are. But if you can alleviate that fear with facts, you can shift a patient into a treatment that overall will be better for them, from a psychological standpoint, and understanding true side effects from treatment versus what you may read or find online or hear from other people who have never even been through it. The goal of alleviating fear is to do so with actual information, with facts. And, a patient can't get that information until they see their physician. I mean, you can get some on the internet, and you can read, but you really want to sit down with your physician and say, what's best for me? And I find that when patients do come in, they leave, I would like to just say they pleasantly surprised, because they've generated this concept of what radiation therapy would be like. And again, so much so that sometimes patients come in almost set on doing a mastectomy or double mastectomy because of what they fear radiation would be like.
You really have a tool that helps in reducing the fear while improving the quality of decision making. And with that, we're at the end of our program today. Thank you so much, Dr. Farber, for sharing the latest information and the developments about ductal carcinoma in situ and breast cancer.
Thank you. It's been my pleasure.
The possibility of getting cancer is pretty scary. And when cancer hits, where do you get the right information about diagnosis and treatment? Who helps you understand that it's okay to be afraid and that it's okay to be scared? I'm Paul Schmidt, and this is the Onco'Zine Brief. Each week, we'll update you about the latest news and information about cancer and cancer treatment. We'll help you with suggestions on how you can talk to your doctor and ask the important questions you need to know so you can take the right steps in planning your treatment. We'll ask the experts and tell you what you need to know and why it matters. To learn more, text the word cancer to 66866 and we'll email you our free newsletter, or visit www.onco'Zine.com. The Onco'Zine Brief is produced by Sun Valley Communication in association with Physicians Weekly and the American Association of Medical Education.
In the United States, over 60,000 women are newly diagnosed with ductal carcinoma in situ, or DCIS, each year, accounting for an estimated 18 to 25% of the total number of newly diagnosed breast tumors. Fortunately, DCIS is a highly curable disease with a 10-year cancer-specific survival of about 97%. Because DCIS is a forerunner of invasive breast cancer, and it is often referred as a pre-cancer, early diagnosis and treatment are crucial for reducing the risk of developing invasive breast cancer. Current treatment strategies include breast-conserving surgery with radiation therapy, breast-conserving surgery alone, mastectomy, or observation. Now, as we've heard from Dr. Farber, a recent survey demonstrated that 53% of DCIS patients' risk score were underclassified and 34% were overclassified using traditional methods, resulting in overtreatment and undertreatment. And we've heard Dr. Farber also talk about PreludeDx. During the 2020 San Antonio Breast Cancer Symposium, the company presented clinical outcomes data on the company's commercially available test, DCISionRT. For more information about this, visit the company's website, PreludeDx.com. And for more information about EHMET Health, visit the company's website, EHMETHealth.com. For us here at the Onco'Zine Brief, we want to thank you, our listeners, sponsors, and advertisers, for your ongoing support. Your support makes it possible that you can hear this program via PRX, Public Radio Exchange, and in the United Kingdom and mainland Europe via UK Health Radio. And you can also download our program via podcast and streaming media, including iTunes and Spotify. For more information about supporting the Onco'Zine Brief, go to Onco'Zine@Onco'Zine.com. If you are living in the United States and want to receive our newsletter, text the word cancer to 66866, and we will make sure that you'll receive our newsletter, which includes an overview of the latest news in oncology and hematology. Thank you all, and thank you for listening. And join us again for our next episode. I'm Peter Hofland, and this is the Youngsteen Brief.
The Onco'Zine Brief is produced by Sun Valley Communication in association with Physicians Weekly and the American Association of Medical Education. Support for the Onco'Zine Brief comes from listeners of this station and our commercial underwriters and advertisers. For more information about advertising, underwriting, and sponsoring options, visit Onco'Zine at www.onco'zine.com/underwriting. The Onco'Zine Brief contains health and medical-related information and is provided for educational and entertainment purposes only. The content in this program is not intended as a substitute for professional medical or health advice and does not replace your doctor's advice and guidance. Your doctor is the best person to answer questions about your personal health. If you hear something in this program that doesn't agree with what your doctor has told you, ask him or her about it.